Tra i pazienti sottoposti alla procedura di TAVI c'è all'impianto valvolare aortico transcatetere circa un terzo ha necessità di effettuare una terapia anticoagulante orale a causa di patologie concomitanti. Interrompere la terapia anticoagulante durante la procedura di TAVI vorrebbe dire ridurre il rischio di sanguinamento, al contrario continuare la terapia anticoagulante vuol dire ridurre il rischio di trombosi. È un bilancio delicato. Per rispondere alla domanda se è meglio interrompere o meglio proseguire è stato effettuato uno studio che si chiama POPular-TAVI, che è stato presentato qui a Londra al congresso dell'ESC, e noi ne parliamo col dottor Van Ginkel, che ha presentato appunto il trial. Dr. Van Ginkel, before going into the study, which are the characteristics of the patient who undergoes the TAVI procedures?
So, in patients undergoing TAVI, these are typically patients with severe aortic stenosis and mainly elderly patients with several comorbidities. So, younger patients, still most of them undergo surgery, but patients undergoing TAVI are typically elderly patients. And these several comorbidities, which most of these patients have, like renal insufficiency, a prior history of stroke or coronary artery disease, increase the risk of, on one hand, thromboembolic events, for example, ischemic stroke, but also the risk of procedure-related bleeding or major vascular complications. So therefore it's really a trade-off of thromboembolic events and bleeding events, and therefore the appropriate anti-thrombotic strategy in these patients is highly relevant.
Yeah, and so you did the study, and what you compared in your study?
Yeah, so this was a study focusing on the subgroup of TAVI patients using oral anticoagulation. That is a subgroup of about 1/3 of the current TAVI population, and they use oral anticoagulation mainly due to atrial fibrillation. And in most patients, oral anticoagulation is typically interrupted a couple of days before they undergo a high bleeding risk procedure. That's also what general guidelines advise. However, there have been some observational studies which showed that continuing oral anticoagulation throughout the procedure potentially could reduce the risk of stroke. So therefore we designed this randomized trial to study the safety and efficacy of interruption versus continuation of oral anticoagulation during the procedural period.
Dr. Van Ginkel, which were the primary endpoint of the study and which were the results?
The primary endpoint of the popular POPular-TAVI trial was a composite of cardiovascular mortality, stroke, myocardial infarction, major vascular complications and major bleeding within 30 days after the procedure. And we observed that the risk of this primary outcome was 14.8% in the interruption group, whilst it was 16.5% in the continuation group. And so the risk difference was 1.7% in favor of the interruption group. And therefore the associated 95% confidence interval exceeded the pre-specified non-inferiority margin. So we had to conclude that continuation of oral anticoagulation was not non-inferior to interruption of oral anticoagulation in patients undergoing TAVI.
Which is more or less the opposite to what you expected.
Yeah, so when we designed the trial, which was based on observational studies, and these showed that continuation of oral anticoagulation could potentially be associated with a lower risk of stroke, and in observational studies they observed no higher risk of bleeding. But that's the reason why we do randomized trials. In our trial, in fact, we saw the opposite. No decrease in the risk of thromboembolic events, but a higher risk of bleeding.
And so the final message, which is?
And the final message of the trial is that in patients undergoing TAVI, which have an indication for oral anticoagulation, based on these data, it would be better to interrupt oral anticoagulation and follow general guidelines on this topic, as there seems to be no reason to continue. It will increase the risk of bleeding.
Interrupt for how many days?
So in the trial, the interruption strategy was at least 48 hours before the procedure. And in patients using dabigatran, which also had renal insufficiency, this was slightly longer due to the prolonged renal excretion of the drug. And also in patients using vitamin K antagonists, it was slightly longer because of the longer half-life of these drugs.